third line choice. Anybody have any questions? Oh, let me back up and tell you, when a patient gets pneumonia on their x-ray, a lot of people are given community-acquired pneumonia drugs like augmentin and erythromycin. This hasn't been, I mean, we personally don't, but there's no downside that we have seen to giving this. So there hasn't been research on it with the COVID pneumonia, but if you start it, that's okay. Hydrochloroquine, initially we thought would be useful, but there's 7 randomized trials now that say it's not, and therefore we do not use it in our hospital. Somebody's asking me to repeat the steroid regime. We start off with betamethasone for lung maturity. So we give that 12 milligrams 24 hours apart. And then on day 3, we start prednisolone, 40 milligrams every day for 8 days. If a patient is really nauseous and having vomiting and GI upset, you can actually use hydrocortisone, 80 milligrams IV Q-day.
Thank you, Donna.
Any other questions?
Tell you what, and we can ask questions to Dr. Johnson after we're completed with the panel. So we'll go ahead and get started with Dr. Bartels. Again, the Vice President, Chief Medical Officer for Blue Cross Blue Shield of South Carolina. Matt, are you with us?
Yeah, Barry, can you hear me?
Yeah.
We can hear you.
Thank you.
Yes, sir, I'm here. Thank you.
Are you on Matthew's iPad?
Yeah.
Okay, wonderful. I just would like to, I'm going to go ahead and rename you so that we know who you are there. Go ahead.
Great. Thank you.
Mm-hmm.
Rachel, are you able to project the slides? And if not, that's
sure.
fine.
1 second, and I will pull them up for you.
So while you're doing that, I just want to thank Dr. Campbell and Rachel for bringing me into the ECHO fold. Just a little background on me. So I've been in South Carolina for 3 years. I'm a former Western New Yorker. I'm from Buffalo. And a good colleague of mine up in New York several years ago, Dr. Ann Greep, had gotten involved in the ECHO project and went out to New Mexico. She's a psychiatrist. And so I've been so curious about ECHO for all that time. This is actually my first despite having an interest in it. And her enthusiasm was contagious when she came back and talked about the great work that the ECHOs were doing around the country. So kudos to all of you for doing this and putting this together. And again, thank you for having me. So there's a lot to talk about from a payer perspective regarding the pandemic. I really focused this on virtual visits, and Dr. Campbell and I talked a while back and felt like this was probably a reasonable place to start. But as you all know, there is a lot that has gone on, and a lot that I'll talk through, and I'm happy to answer questions at the end in terms of other areas where we've adjusted and adapted to the pandemic just like everyone else. So,
Dr. Bartel, sorry to interrupt. Whenever you are ready to move to the next slide, you can just say, go ahead, and I will move forward. Thanks.
Perfect. Thanks, Rachel. And yes, we're going to stay on this slide for a little bit, so okay, feel free to have a coffee break because I have a lot to say about these 4 bullet points. But I put together this very brief presentation just to kind of frame up the conversation, but I definitely want it to be interactive. I know the virtual world makes that a little challenging. The other thing I'll say before jumping into this slide is we've also had the benefit of being part of a large family of Blue Cross plans around the country. So we've been able to learn from other states and other payers as to what they're doing and how they're adapting. So our decisions aren't being made in a vacuum, similar to how I think ECHO functions. You know, it's all about sharing knowledge. So this slide here with the 4 key bullet points is where I really want to focus. So prior to COVID, we really did not have many medical providers adapting to telehealth, and I'll get to some definitions, but think of virtual care. We actually, like other payers, had our own sort of direct to consumer solution, a telehealth option that they could access. But despite our best efforts, we really didn't have widespread adoption by our provider network to start delivering care to their patients through this virtual format. And it wasn't unique to us. All payers, I think, were in the same boat. People could see this as a future, you know, delivering care this way, but I don't think that our health systems were and practices were set up to accommodate it. I think that presented a real challenge. You know, how do you meld inpatient care with virtual care? How do you flow that through a day? You know, so it's very understandable that why that adoption didn't occur more quickly. But then, you know, this thing called a global pandemic happened, and in more ways than one, we really weren't fully prepared. The payer side, and I'm sure the providers as well. So we really went from virtually no network providers using virtual care to well over 6,000 now.
Yeah. Hey, wait, how many are there? Are there only 3 of us?
I'm sorry,
Oh,
Dr. Bartels, we have someone who's not muted. I will go ahead and find out where that is. 1 second. As a reminder, everyone, please make sure that they are muted.
Thanks, Rachel. Mm-hmm. So pre-COVID, very minimal adoption. Post-COVID, in the matter of weeks, we had rapid adoption, and you can imagine, right? Everything was shut down. The practices weren't getting their patients. We're still in something, you know, that everyone knows as a fee-for-service reimbursement world, despite, you know, our everyone's best efforts to move to value-based care and reimbursement. But the reality is the reality, and people needed to access their doctors. So I will say it was like a tsunami of requests, and we had a very small team, but very efficiently working through and getting providers access to be able to deliver virtual care to their patients. There's a kind of a standard process that providers go through, you know, an approval. There are requirements too that I'll speak to in a minute. The interesting thing is what the pandemic really caused us to do is look at things very differently. So I'll give you some examples, and some of the approval that we had prior to the pandemic required more stringent technology that was HIPAA compliant, that the providers went through an application process, that in certain situations we'd actually perform site visits. Yeah, you're fine on this slide, Rachel. But the concessions that we made to quickly support both our members and the providers were drastic. So we temporarily removed the requirement of HIPAA compliant software. We knew that was a barrier to quickly adopt. And so this really allowed providers to use things like FaceTime. We also expanded the types of patient visits that were allowed in telehealth. So not just the traditional things like acute care, but other visits and expanded visits. Prior to COVID, we only allowed about 4 codes, and those were the typical acute visit codes. But we were expanding to allow various things like well visits, wellness visits, and numerous other services. We also made the decision to pay at parity temporarily to existing provider rates. And I'm going to share a little bit about how we came to this, but it was important from our perspective to really support the physicians, not let payment be a barrier to providing care, because we knew that patients weren't coming in. And we'll talk more about how that may look in the future too. Additionally, we allowed payment for telephone visits, which we hadn't prior to the pandemic, nor had many or any payers that I know of. We opened up virtual care to speech, occupational, physical therapy as well. And that was a lot of debate on our end, and at the end of the day, there was a lot of good discussion about whether or not that needed to be the care that was delivered hands-on through manipulation and that type of thing. But it was good discussion, and I think we made the right decision to allow that. We also did some interesting things, like opened up E&M provider codes for the emergency department, inpatient, observation, and even critical care visits. Knowing that providers were spread pretty thin, and it was more important that we were enabling them to have some type of visit with these patients in those settings. So that, believe me, and if you had asked me this back in January before the pandemic, I would have said no way. But through a lot of debate and discussion and requests from our network, we absolutely saw how that would add value, given the state that we're all in. Additionally, we allowed pediatric well visits, and I'm a pediatrician, and I was probably the most vocal that saying you can't do that through a video. But our compromise was, yes, you can do it, but then the expectation is please follow up for the objective measures that need to occur, the physical exam, and then any immunizations and testing. So the expectation is that's part of the visit, but the visit needs to be completed in person. And we allowed home health and hospice visits to occur virtually. So as we were forced to make many rapid COVID-related coverage decisions, we developed some guiding principles. And because I can tell you, it was very difficult to work through these, and we wanted to ensure that our members had access, our providers were able to deliver care. So the four kind of principles that we came up with very quickly was, and this relates to telehealth, but also numerous other COVID benefit changes that we made. The first one was, does this add value for the member? The second one was, does this enhance sustainability to the providers? The third was, does it harm the member? And the fourth was, does this harm our business? And those were a framework by which we were operating to make quick decisions. And it actually gave me a lot of comfort, because if we could answer those in a way that got us to the right decision, we all felt more comfort that we were doing the right thing, because some of these were unusual, to put it mildly. I had even joked at one point we'll be delivering infants by virtual care, but that doesn't sound so far off now when you think about it. I think the decisions we've made are right. The questions that are to come are what next. So Rachel, you can go to the next slide. So I have this is just a visual when it pops up. Distinguished.
Question for you too. Are we holding all questions until the end of your presentation?
No, you can go ahead and ask.
Okay, we have a question that's come in about understanding Lancet and NEJM retracted some of the hydrochloroquine studies. Can you comment on this?
That was for me. Okay.
Yeah, we'll save that one for later.
Okay, thank you.
Thanks, Rachel. So this slide here really is just something that we share with providers, and I felt it was important to share with you. Terminology matters, and I'm moving toward more using the terminology of virtual care. Telemedicine is used interchangeably with telehealth, but for simplicity and for the audience on the meeting today, telemedicine we define as provider to provider virtual meeting, so to say, and telehealth we have defined as provider to patient. So if there's any confusion as I go through this, just let me know. But we have policies, as you can see on this slide, for both. And we pre-pandemic, we had, criteria that in the situations where these were reimbursable. So Rachel, you can go to the next slide, please. This is just, I had mentioned we had an approval process for providers to be able to deliver telehealth to their patients. And this actually is a application for both telehealth and telemedicine to be able to be qualified for reimbursement for those services. It's our due diligence, right, to make sure that providers do use HIPAA compliant technology. And then there's another page after this that I didn't include, but it asks to list the names and MPIs of all the providers who are using it. And then we would load that into our claim system to adjudicate. I thought this was interesting. Approximate to today, I checked in with the team, approximately 150 OBGYN locations are using telehealth. And remember, pre-pandemic, we had 0. So that's quite remarkable just from the OBGYN perspective. And that's locations, not individual providers. So that probably encompasses many more than 150 people. Yeah, you're good on this slide. Thank you. So I included this screenshot just because we had, with the pandemic, we had to make rapid decisions, like I had mentioned earlier, on everything from telehealth to testing to coverage, cost, copay waiving, and you name it. This has been the topic of discussion every day since I would say mid-February at our plan. But we had updated our website in very fast order and worked with partners to ensure that members, specifically members who had concerns about COVID, had access to virtual care. There's basically 3 options on the screen, but the bottom is the one that we've been focused on today, which is our network providers utilizing their own telehealth options. But the website was worked on in collaboration with DHEC to ensure that when patients went through a triage process online, that they were being routed to appropriate sites for possible testing. And we, as I mentioned before, we have our own telehealth solution direct to member called Blue Care on Demand through a national vendor that was available as well. But our actual preference during the pandemic was that people were accessing local sites such as the DHEC endorsed ones, as well as Doctors Care on Demand or their own provider, because we felt that those who were in the state knew best where to send people. So a lot of quickly navigating and ensuring that we were partnering with the providers and DHEC to get people to the right place. Rachel, you can go to the next one. So this I thought was very interesting. This is our data and analytics team have been working over time since the start of the pandemic to create dashboard views of various things, right? Claims that are coming in that are COVID related, testing. This one is specific to virtual care claims that we have received. And that flat line is real. That's not a data artifact. We were receiving very few, although we were receiving claims from providers, just the ones who were certified to provide virtual care. And then you look at the time of the pandemic, it spiked dramatically. The downward slope on that toward the end of that line is partly a data artifact due to a lag in claims entering our system. But we've definitely seen in the last month or so some rebalancing back to in-office visits as practices ramp up and people get more comfortable coming in. But no one on our end expects a return to normal, back to where we were previously. Rachel, you can go to the next one, please. I'm going to kind of go over this real quick. Just another view showing the age distribution of our members who are utilizing virtual care. It kind of mirrors our demographics of our membership in total. But again, it's clear that the pandemic has accelerated many changes, and virtual care is just one that has finally found a place in the larger ecosystem of care delivery. It's certainly not perfect, and there's concerns that need to be tracked and addressed, but it is a convenient, safe way for people to get care. It's clear people are embracing this, as are providers. This is my next slide is my last one, and I'll stop there. So this was from this past weekend. You know, the spotlight is on this technology for sure. And we and all other insurers are exploring what the future of virtual care will look like. You know, and as fiduciary agents of other people's money, most of the time, we also need to ensure the cost of virtual care is not additive in the aggregate sense, but that our members are getting safe and complete care as well. And you all know this, not all services are fit for virtual care, but many are, even ones I didn't think ever would be. So my own thinking on it has certainly evolved. And you know, I'm sure many of you are tracking this, what's happening with Medicare and the expansion, both in rural areas. The amount of money that's been invested in telehealth is significant. So I don't have the answer here. I just know this has been a game changer from one aspect of care delivery the pandemic has brought on. I think it's a good thing ultimately, but I don't think it's a one size fits all either. So thank you, and I'm sorry that took a little longer, Rachel, but I appreciate you letting me go through that, and I'll pause here for questions.
Dr. Bartels, thank you really so much for talking to us. It gives us a perspective on something that we've seen grow, and I think you're right, it is here to stay, and I think it's going to revolutionize what Donna and many of us have tried to start with telehealth and telemedicine, and that distinction is really an important one to differentiate. So I really appreciated that. I think I'm going to hold questions for after we have the next two, but our next two panelists are not going to have a lot to go over, but just kind of to talk about the impact on the practice of high-risk obstetrics and obstetric practice in general. Have Mary talk and then just hand the microphone over to Michelle, and then we'll take questions for all the panelists, including Dr. Johnson after that. So next up, Mary Evans.
All right, hi, thank you so much for having me today. I really appreciate the opportunity to speak with everybody. So we've made many changes to the way that we are conducting patient care here at Maternal Fetal Medicine, hopefully to help decrease the risk of transmitting the virus, not only to our high-risk patients, but to our staff as well, and to also make sure that our patients are still getting the same level of care that they're used to receiving, even through the pandemic. Currently, all of our in-office patient visits are being asked to come in, get screened for temperature checks and symptom checks. Then they're asked to wait in their cars once they're checked in until we're ready to call them in for their visit. Our non-COVID related patients that are not high risk and don't need like an immediate visit, one of the changes we made for those patients was to do telephone visits or video visits, depending on what they need to be seen for, whether it's a preconception consult, or for our diabetic and hypertensive patients, we do telephone visits to go over their blood sugars and their blood pressures. Once we started actually receiving referrals for COVID positive patients, we also again had to alter how we were seeing them in the office. So we started scheduling those patients for a video visit with our MFM providers within 1 week of receiving their referral from their primary OB office. Once they have their video visit and it's completed, depending on their underlying health status, where they are in their gestational age, and the last time they were seen by their primary OB provider, whether or not they need like genetic counseling, whether they need prenatal labs to be drawn, or any antenatal testing, we then schedule them for future appointments in our office. Some of those visits can also include either a weekly telephone visit to check in with them, or a video visit, whichever they prefer. Monitor their symptoms and their overall health until they have recovered completely. We're also doing some drive-by visits. Basically, the patient comes by and stays in their car. Our staff will go out to their car and get their vitals, also monitor fetal heart tones, of course in full PPE, until they've reached that recovery stage. We're also doing video visits for genetic counselors for genetic screening, and then have subsequent lab draws done in our lab that's here in our office. Ultrasound appointments are also being scheduled for those patients that are COVID positive. They do get scheduled as the last patient of the day. They're asked to call us once they arrive to the parking lot. Once they do and all of the other patients have been cleared from the office, we bring them in through a side door that's designated for COVID patients so that they don't have to come in through our actual patient lobby. We have a designated room that's set up for ultrasound that's just strictly for COVID patients. That way, multiple of our rooms are not being used for that. The staff, of course, still wears full PPE during that visit. Typically, once the COVID patients have reached their 14 days from the onset of their symptoms or from their positive test if they're asymptomatic, and as long as they have been afebrile for 3 days without the use of antipyretics, we do start to see them for routine care in the office using standard precautions. And we do follow all of our COVID patients at the very least once a week for 4 weeks up from their initial test. And once they fully recover, as long as the patient and their baby do not have any other health issues, we then release them back to their primary OB provider. And I'll turn it over to Michelle.
Michelle, you're muted.
There we go.
Wonderful.
Good afternoon, everyone. I'm Michelle Flanagan. I'm the OB Outreach Educator for the Midland region. So Dr. Campbell asked me to talk about some of the changes that we have done at Prisma Health Richland for our staff. As an educator, one of the requests that we had was for us to begin site managing. At the Prisma Health Richland Hospitals, the site manager role has been to help ensure that the staff going into positive patient rooms or PUI rooms were appropriately wearing the correct PPE, both donning and doffing their PPE. So we helped check people off to make sure they knew how to correctly put on their PPE and take it off, as well as monitor everyone who was going into a positive patient's room. As the Midlands OB Outreach Educator, one of our hospitals reached out to me recently and asked a series of questions to know what everyone else was doing about their pregnant patients in the hospital. How were they managing visitors, allowing for baby to stay in the room, et cetera. And I surveyed all of our hospitals in our region. So that was 3 level 1 hospitals responded, 6 of the level 2s responded, and then our 3 level 3s all responded. And the easiest way to say is that everyone is across the board doing something a little bit different because it needs to match what each individual facility is able to offer and provide and meet their guidelines from their hospital or their umbrella hospital that they're underneath. So it was very varied as far as whether or not a support person was allowed. CDC, ACOG, SMFM are all recommending that it is okay for a patient to have an emotional support person in the room for that laboring, birthing mom, and how each hospital is addressing that is different. And I can share more information afterwards with anyone who's interested in seeing kind of what you're doing at your facility versus what we're doing at our facility to help save time and allow for questions and answer to come in to play here. And I did want to also note that there on the CDC website this week and early last week, there were several updates made to the recommendations for guidance on breastfeeding, rooming in with the neonates, risk factors for neonates, as well as care for the laboring mom.
Thank you very much, Michelle and Mary, and Dr. Bartels. I'm going to stop there and let Rachel kind of orchestrate the questions for each panelist. if you have some by chat, if you want to share those.
Sure, we can go ahead and do that. Let's see. At this moment, I don't have any questions coming in through chat. So what we would love, I'm sure Dr. Johnson has some questions for the panelists too, right off the bat, I can tell. But we can go ahead and start questions, and please, the protocol would be if no one is speaking, please feel free to unmute yourself in this venue and to ask your question or make comments. Otherwise, you can use the chat feature, and myself and we can all see the chats coming in. Dr. Johnson?
Unfortunately, I only replied to Dr. Campbell about the New England Journal article and the Lancet article.
Okay.
But basically, that had over like 8,000 veterans in it, and the data was made up. And so I don't know how the publishers found it out, but once they found it out, they retracted the article. And so hydrochloroquine has been looked at in 7 other randomized trials and hasn't helped. We're still hearing it on a national scene because politicians have gotten into the treatment of COVID viruses, and it has not been shown scientifically to help.
Any other questions for Dr. Bartels, Dr. Johnson, Michelle, or Mary?
Dr. Campbell, it's Matt Bartels. I had a question for the folks. I was just curious how your adoption of virtual care, have you integrated it into your practice? How's it going? What challenges have you had? I'm just more curious as to hear how it's working.
I can certainly speak to our experience, and we have incorporated it into our daily care. When we have patients, and we actually, I think the other side that Mary touched on just briefly, and that is we have a lot of patients asking for it, patients that are nervous about exposures and coming into the office. They will call and say, well, why can't I do my visit virtually? And we are doing that, especially with the consults. We see a lot of consults in our office for diabetes, for hypertension, other medical complications of pregnancy. Most of those patients end up requiring an ultrasound at some point, but we do a lot of those initial visits by video, and patients are still waiting in their cars to come in if that's what they prefer. So it works very well, and that's why I said initially I think that this mode of taking care of patients is going to be something that we really will utilize more and more as we move forward, and I appreciate the ability to do that. The one area that I will mention to you from a physician standpoint and how to interact with insurers, our resident clinic is a population, it's very interesting to me, but they absolutely do not like to do video visits. And when we do have the opportunity to do a virtual visit, they want telephone visits. I mean, they will not participate in video visits. So from a provider standpoint, to you and other insurers, I think that there's going to need to be a provision in some way to continue some telephonic virtual visits as well, because it's, you hate to say you just can't do it that way because we're not going to be reimbursed for that. And we don't. We do those visits, but we also know that the reimbursement is much less than what you will be able to obtain with a video visit. So I'd be curious about your comments and other people's experience in that realm, but it's a real issue in our resident clinic.
Yeah, that's it. Well, I totally appreciate that, and having been on that side for so many years, and I feel like our ancestors did us wrong. The lawyers had it figured out, right? They could charge by the minute for a phone call. Doctors, we gave it away for free. I think the one challenge, Dr. Campbell, that, as I mentioned earlier, that we're going to be faced with as a payer is to make sure that we're doing our part to not have additive costs for technology. Right? You know, as you know, we and all of us are responsible for kind of the cost containment efforts, and that's not the primary driver, but that always comes into play when you're talking about the payer, right? So I don't have an answer for you. I do know we've gotten that same feedback from numerous other providers. So I'm happy to have a follow-up conversation with you once the decisions have been made. But as you can also imagine, there's a lot of people on the plan side who have a vested interest in ensuring that we have a go-forward solution for the new technology. Even though telephones aren't new, the fact that we're using them the way we are today is new. We're actually doing more care by phone and video than we ever have. So I'll follow up with you once I learn more, but right now it's status quo until we can kind of see how this pandemic plays out in the state.
Any other comments or questions, Donna?
Well, our diabetics really like having telemedicine because they come to our office every 1 to 2 weeks, and it saves them a lot of time. Our routine patients, I think they prefer to be seen in person if we can social distance in our office.
Yeah, that's great feedback, and it makes sense, right? You're saving people the hassle, and I felt that same way, you know, that there are certain people who just want to see and be in the room with you and have that conversation, and then there's others like your diabetics who have to come so frequently that this is a huge time saver. But thank you.
I will also echo that my husband developed congestive heart failure while we've been in the isolation, and he can't get his computer to show, connect with video. So they've been calling him and talking with him and getting his vital signs and his weights and stuff. And he actually enjoys it, like Barry said.
That's great. That's great.
I'd also like to add, as a part of, I'm a team member on the Women's Reproductive Behavioral Health team. And for those patients who are pregnant and postpartum and living in rural areas, the changes have really helped, and our numbers have increased dramatically and coming to the forefront, as we already know, showing the high need that pregnant women have for behavioral health care during pregnancy and postpartum. And due to the changes with insurance, that has assisted these patients to get care.
That's great feedback. Thank you, Rachel.
And the person in charge of that program, who works closely with Dr. Johnson as well, her name is Dr. Connie Gill.
Okay.
And we provide care. We have a whole team of psychiatrists that specialize in women's reproductive health. And we work directly with OB offices, and their patients are able now also to be referred directly through this platform to talk with us via direct to consumer, as you will. Or if it has to switch to phone, it needs to switch to phone in some cases because people are in rural areas and struggle with internet. So that phone coverage, I would echo, is very important as well.
Great. I appreciate that.
Another good point. Any other questions for anyone on the panel? I really would like to thank the panelists and Dr. Johnson for participating. I think this is a very timely discussion, and it's not going to be put to rest anytime soon. I think it's going to see tremendous growth in the future, even after the pandemic wanes. Did you have another question, Rachel, that came up? No? Okay.
There was just a comment, and thank you so much, Ellen. Just that their participants are loving to do the visits virtually, and it's actually increased significantly, and it's reduced the missed visits. That's something we're looking at too. No-shows, and our participant, thank you, Ellen, has said it has reduced the no-shows for them.
And I think it has certainly, I think in our practice, it's increased the number of visits for mood checks and those postpartum visits, the virtual visits, because they can get those done relatively easily without having to come in. Donna, I'm sorry, I didn't mean to interrupt you.
I was just going to mention one other thing. I don't know how many times a week you get this call, but about whether or not to use DVT prophylaxis in COVID positive patients.
Yes.
If the patient is mildly symptomatic or asymptomatic and is at home and doing things like usual, we haven't been using any heparin at home. But if they come in the hospital, we do 5,000 international units BID. And if their if their D-dimer is 6 times normal, we have actually put them on therapeutic heparin, but we've only seen one patient this sick thus far.
I agree with all those things. That's the way we manage as well. Well, thank you again for the panelist participation, and I look forward to our next echo, which will be in 2 weeks, and you will receive those invitations as we move to another topic. So I'll leave that to you, Rachel. Thank you.
Yes, and thank everyone so much for staying on longer. We usually go until just 1, so we really appreciate it. Our next series, which also incredibly important during this time, as there's been a very large rise, is substance use disorders in pregnancy. And we have a whole team of specialists who are going to address various topics dealing with pregnancy and substance use. So we really certainly hope to see you. And again, it is the 1st and 3rd Wednesday of each month, and I will be sending out an invite to you. If you have any questions following this, please feel free to email me, and I can get those questions to our panelists or Dr. Johnson or Dr. Campbell. Thank you so much.
Thank you.
Thank y'all.